Okay, so it's just 2 minutes past 12. I think we'll get the ball rolling if that's okay with everybody. Just by way of introduction, my name is Tony Canavan. I'm the Regional Executive Officer for the West and the Northwest, and I'm joined on this webinar by most of my colleagues from the new Regional Health Area Management team as well. And the purpose of it really is to provide you with a further update on the changes that we're implementing across, not just across this region, but across the country as well, and across the HSE more generally. I guess one of the things that really has become very apparent over the last couple of weeks, in particular, is that we are making changes, and we are trying to, I suppose, design and implement changes to the management structures, and to do it in a way that makes sense, obviously, for patients. But when you're trying to do that across such a significant range of services and large body of staff, it's really important that we try and get the communication right. And there's been a couple of lessons for me over the last couple of weeks about how difficult it is to do that in that context. So I'm hoping that today will help. And one of the key things I think that we've picked up on is that because this area is complex and affects different people in different ways, a good way of dealing with the communication piece is to offer people the opportunity to ask a question and get an answer, hopefully from the right person, or the person that has a bit of information. So partly today is about that. Will be possible for people that are attending to ask questions through the chat feature on the webinar, and I think we've already had a few questions even submitted in advance. But I would strongly encourage you to do that. I think that's really part of this process. It's the question that you ask may help somebody else to understand how these changes impact on themselves. And certainly from my perspective and from the perspective of the Regional Health Area Management team, our job here this afternoon is to try and answer your questions as best we can and as honestly as we can. Even if that message or the answer to your question isn't necessarily what you would want to hear, but make sure that we leave you with good quality information at the end of the discussion. It's not that long since we had a webinar, and in some ways that kind of some of the changes taken place. But one of the key features of the webinar this afternoon is that we're hoping to have a discussion on the networks of care. So Pat Nash, who's our Regional Clinical Director, is going to lead out on that discussion, and it's a really important part of the discussion because it's important that we ensure that is part of our thinking in whatever structures we're designing for our region going forward, and Pat will take us through that as well. So we have made progress since we talked the last time with the rollout or the development of the regional management team, and most of the posts at the regional management team are filled at this point. So all of the IHA managers, the regional clinical directors that I've already mentioned. So it's probably easier for me to describe the posts that haven't been filled yet. But that are in process. So right now we are still in the process of appointing through recruitment a regional head for planning and performance. We expected the interviews for that post will probably take place now after Christmas at this point, and probably towards the second half of January. We have a vacancy on the regional management team as a regional lead for disability services, and that post hasn't gone out to advertisement yet. We're still in the process of finalising the job description or agreeing the job description for that post with the Department of Health, so that's not quite as far along. And we have advertised for a regional director of nursing and midwifery for our region, and I would expect the closing date for that post is coming up very short. So I'd expect again that the interviews for that will be held in January, and hopefully then that we'll be in a position to fill that post relatively early in the new year. We've also, I suppose, had the benefit of time passing by and using that time then to bed in the new integrated health area management arrangements. And just to refresh it in your memory, we have appointed our IHA managers, and and the regional management team structure has taken over from the two CHOs that are relevant to our region, but also from the hospital group. And so responsibility for the delivery of services sits under the regional management team now. But we're working our way through an interim period where the existing heads of service within the community services are continuing to discharge their responsibilities as they were before the 1st of October. And we're using that 5-month period from October to the beginning of March to design and implement the next layer of management, which is underneath the IHA manager. So that's just to refresh that in your memories. But what has happened, I guess, over the last few weeks, as you can imagine, because services have continued to be delivered and they need to continue to be delivered, the IHA management managers have become more embedded in services and are getting themselves out and about and seeing the various services as they exist in their own patches. We've also, I suppose, gone through quite a bit of communications to try and explain to people this is what we're doing at IHA level, and even, for example, at the moment this week we're engaging with public representatives just to outline those structures to them, because it is important that people understand what the structures are and what we are trying to do. We've also, I suppose, if you were to ask me where have we spent most of our time on the new structures in the last 3 to 4 weeks, well, really it has been working together to try and figure out what the structure underneath the IHA manager will look like. And there's been a couple of things that have been really important in that. We have been looking at it in the context of the existing structures within our health services, but also we've been looking at it in the context of the networks of care and how they can work together. And I'm going to leave Pat to maybe explain that when he speaks to you in a few minutes. But really, we've spent a lot of time working on that internally within the region and trying to figure out what that would look like. And I think we're making real progress in that regard. I think for all of us, the picture is becoming clearer now. One of the things that has emerged from that is that that we have come up with, not just for this region but for the country, we've come up with a framework that describes how the management structure will look underneath the IHA manager, and this that framework itself has been accepted by the steering group, which is overseeing the rollout of the regions just this week. So it is an important step for us. It's another important milestone, I guess, for us. And what that structure will do, or what it seeks to do, is, first of all, it seeks to ensure that we achieve integration of our services down to the lowest possible level. And I think it's important that when I say integration and when I think about integration, of course, I'm thinking about integration between hospital-based services and community-based services. Absolutely, of course, we're thinking about that. That's important. But I'm also thinking about achieving integration between some of our existing community services. So, for example, integration between primary care and mental health, primary care and social care, and so on. So I think it is important that as we're putting together these management arrangements, that we think about integration in as broad a way as possible and in ways that make a real difference for patients and how they access our services. The second thing that we've managed to capture in the framework is the idea of developing a flat structure. And what that means is, what that means to me is that the number of steps between me and where services are delivered, that those number of steps are kept to the absolute minimum that's required in order to be able to organise our services efficiently. There should be no layer of management within our services that doesn't add value to patients, add value to service users in terms of the services that they access. And I do think that the framework that we've come up with gives us the potential to achieve that. It also gives us the potential to achieve really good clarity about who's responsible for what and who has authority, or who is entitled to decide in respect of various issues. And that's really important generally, but it's also specifically important when we, in the context of our relationship with the regulators, including HICWA and the Mental Health Commission. So for our older people residential services and our disability residential services, and of course our approved centres under the Mental Health Commission, it is really important that we have that clarity. So the new framework that we have come up with and that was approved this week gives us the ability to do that. What it doesn't do is it doesn't kind of define exactly how this is going to look within our region. So there is another step now, and while this was an important milestone this week, the next step will absolutely require us to take that framework and to look then and see what would that actually mean within our region, and what would it mean in terms of the services that we're providing in all the various locations that we're providing them, and also how would it look in the context of the networks of care. And as I say, Pat will pick up on that as well. So I do think that while when I look back on the last 4 weeks or so, there's been an awful lot of work done, particularly a lot of work done within the region. I think that work has been very effective in helping us to move this issue on. It's clearer in our heads how services can be managed and how they can be structured, for sure. I think certainly there's a lot more clarity coming to the involvement of the networks of care and how that can work across our region, how that can be of benefit to patients. And I certainly think that the work that we've done within this region not alone has helped us, but has helped to shape the national picture as well, which I think is important. That we would be, if where we can, leading the way or demonstrating how things can be delivered. I do want to, before we finish, I want to outline and go back over some of the next steps. But if it's okay, what I might do at this point is I might ask Pat to take us through the piece on the networks of care, and then we'll go back over the next steps before we finish, so that they're clear in everybody's minds before we close out. Does that, and just to remind again for everybody, please do send in questions. Use the chat feature to do that. Caroline is keeping an eye on it, and we'll put them to us in time as well. But really, the more questions that you can ask and that we can answer, I think the more clarity we'll all leave this webinar with at the end of it. So Pat, if it's okay, I might hand over to yourself, and I think you have a few slides that you want to share as well.
Yeah. So welcome everyone. I suppose the people who don't know me from the hospital system I'd be known, but from the community I wouldn't necessarily. I'm the regional clinical director for the West Northwest. That previously was the chief clinical director in the Sale Hospital Group, and I am still a cardiologist in Galway as well. So I suppose my role here this morning is just briefly 2 points. One is looking at how we implement the regional structure, how we agree the structures we're going to roll out, and then the governance framework, which I'll be leading out with the IHEA managers, how we design and roll out a new governance framework for the region going forward. And then secondly, just to introduce the concept networks of care. Networks of care is synonymous with what we've had in the acute hospitals of managed clinical academic networks, MCANs, previous Lifer directorates. So I suppose they're a strategic regional structure to provide support and set the strategy, ensure the quality and safety, and provide the oversight to help enable us to be assured about the services at a regional level. And I suppose it's going back to what Tony said again. What's the for the region? We want to integrate the community and hospital and acute services. And I've seen, being a hospital head, I see where we don't have integration and the barriers that puts in place for patients and for all of us, both the hospital and the community, in trying to ensure that the patient pathway. And I suppose key to all what we're doing is that the patient and I mean, I know a patient or service user have the most streamlined pathway, and that our governance structures are aligned to support that. That's a tall order. And I suppose we're serving a defined population of the 6 counties, which is just over 750,000, and that we want to design the services to make sure that there's consistency, that they're integrated, and that we provide a regional service. And I suppose the focus is on how we develop a new corporate or managerial governance structure in tandem with developing a clinical governance, being the networks of care. So Caroline has control of the slides there, haven't she? And I suppose the key objective is we have 4 IHAs, as everybody knows, but the networks of care, there's still national work going on what is a network, how many there should be. And in the initial document that was developed, it's nearly 8-9 months ago now, suggested 9, which and the 9 that are suggested is medicine or hospital medicine, extending into include the community, particularly the enhanced community care, perioperative surgical services, women's and infants, children, mental health services, diagnostics, including radiology and laboratory, cancer services, disability, and older person's network of care. And I suppose the idea of a network of care, it's a clinical governance structure, it's a framework to be able to ensure the implementation of the model of care. And the model of care is a service we provide and ensure that we have as consistent a service between Donegal and Galway as we possibly can for our patients. And I suppose as we progress to the rollout of the structure, I call it co-design, and I've been corrected that this co-design involves the stakeholder, the service user, and that is a key component as well. But it's the integrated design of the networks of care as we roll out the structure under the IHA, and that I suppose we're looking at a population based at the community health network, community health area level, how we can integrate from the bottom up rather than the top down. And I suppose people live in a defined geographical area, how we can ensure that the services at that level are as integrated as possible when and if they need acute care, then how we can ensure there's an integrated approach to their care, particularly at the egress or discharge from hospital. So we have agreed a structure and how we're going to implement the region. It's a 6-step approach. We've done work initially just defining what the vision and mission for the organization, for the HSE, for the region, the West Northwest region. We'll share that with you. That is, we're still awaiting feedback and it's still in draft form, and it will be shared. And then also setting a clear goals, objectives, and guiding principles for the program of work, which is and we have draft goals and guiding principles, which there is ongoing with the engagement about what they are, and they will be for the program of work, which is the implementation of the regional structures. We have the governance. The governance structure we have. I'll show it you on the slide coming. We started work on documenting what is the as is in our governance structures currently between the two community health areas, and of course we have to be cognizant of the fact that CHO1 in the Northwest has lost Cavan Monaghan, and part of both the leadership, some of it is Cavan Monaghan based, and that adds a difference and a complexity to it. So and then I suppose it'll be down to the design and engagement with design, the implementation and engagement, and then refinement and further enhancement over the coming years. But I suppose the target is to have the initial design and begin the implementation from the start of March, which is when the transition period. The oversight group for this team for this is the regional management team. The RMT is it's shortened here, led by Tony, and then the program steering group, which we are in the process of developing the terms of reference, and we will be looking for involvement from as wide a group as we possibly can to have a steering group, and there'll be a lot of different work streams off of that, chaired by members of the steering group to address specific areas. The PMO team, the program management team, that's the teams that exist in CELTA, in the hospital, in the two community organizations are supporting this, and there'll be a smaller, I suppose, leadership team, myself, the IHA managers, to progress and oversee this project and report back to Tony. Move on there, Carl. So I'm not going to go through these. We'll circulate these and the guiding principles about what the design, and these are based on the national guiding principles, and they're self-evident, but I think there's a lot on these slides and we can share it. But looking on the left is the kind of the core functions of the guiding principles. But I suppose overall our objectives are threefold: design an integrated governance structure that brings the corporate, the managerial structure, and the clinical governance structures of the networks together, and make sure that it's as integrated and for patient focused as possible. We need key priority is the engagement, and this is part of it because we need to get feedback from the ground, and it's a very large organization with over 23,000 employees that we are sharing what we're doing, and that's and getting the feedback. And I think many people will be in roles will be asked to be involved at the various work streams and how we design specific aspects of the future model based on the guiding principles that we've outlined in the previous slide. And I suppose we'll be agreeing an implementation plan and then how we lead out on it. And I suppose this will be a live and active process that will need to be adjusted depending on on our learning as we go along. And it's going to, and I suppose the other thing which I probably didn't clear, there is national guidance on this, and we'll be ensuring that we're consistent with the national principles, but we'll be designing it to northwesternize it so that it is appropriate for our population, our geographical, our low density, largely dispersed population. And I suppose from the hospital side, we have all statutory hospitals rather than the voluntary hospitals, the big Dublin hospitals, which is different models of governance. So I suppose we're taking the national, but we'll be adapting it to suit ourselves. So the networks of care, the idea of this concept isn't new. It's to provide the framework for the clinical governance. The clinical governance is being assured about the standards, setting the strategy. And I suppose if I summarize it in three things, it's setting the strategy for the delivery of the relevant services, providing the quality and safety oversight and support for the services, and then helping to provide assurance with regards to the performance metrics, the KPIs we put in place for the service. And we've had this, which there's always a concern, is there a conflict of accountability between the MCANs and the sites, which we had in the hospital group? And I think it's much more collaborative rather than a dual governance structure. It's an integrated governance structure that's focused on the patient pathway and providing the relevant expertise. And I suppose, if you summarize what we want integrated care, and we want a high reliable care, reliability that it's safe, high quality, and that it's consistent across our region is the core fundamental. And of course, which I have said, but that it is patient and service user focused, and that we can ensure our governance structures enable rather than create barriers for patients. So, and that it's multidisciplinary, which I may not have emphasized enough, that these networks of care are multidisciplinary, that they like clinical leadership, but it's a multidisciplinary clinical leadership involving medical, nursing, HSEP, with administrative quality and patient support, and that these are regional structures. So I suppose going back to the three things again of network, they're helping to set the strategy for the relevant area, be it women's and infants, maternity services, or disability, helping in supporting the delivery areas, the hospitals or the community areas, and the quality and safety management and service improvement. And then, and thirdly, in helping in the regional, putting the processes in place to be assured around the services, and that we can, the regional structure can be assured, and we can provide that assurance back to the national. And I suppose it's building on the work that we did in the hospital group. So that is all I was going to say there. And I suppose we look at if you look at the IHAs and the networks of care, it's an integrated matrix of the IHAs and the organization underneath the IHAs, their geographical based delivery of the healthcare. The networks are there to set the strategy, help support the IHAs in the quality and safety and service improvements aspect, and help provide the leadership team with the assurance around the relevant areas of the service. Thanks, Tony.
Thanks, Pat. Thank you. So we have a couple of questions in. Do you want to maybe start the ball rolling, Caroline, with the ones that are in already, and we'll take it from there. We'll try and direct them to the most appropriate person as well on the regional management team, if we can do that.
Perfect. So the first question, we do have about 20 that were put in when people registered, and we'll start with those and then we'll move on to chat. So the first question we have is, where staff will be under new management from transition in March, when will this be communicated?
I can't put a date on that just yet, but I do think it's important that people would have that date of the 3rd of March firmly in their minds, and that we will try and ensure, as part of the rollout of the new structures, that we give people as much time as we possibly can. The reason I can't put a date on it is because there is work still to be done, and I wouldn't underestimate the amount of work that still has to be done. While we've given a good bit of time to trying to figure out how We will do this within our own region. There's still more work to align the existing CHNs, the existing services, and grouping those together and to kind of come up with a way that makes sense for our region. I would be hopeful that we'll get that done as early as possible in January, but it might mean that people are getting notice of the changes with relatively short lead in time. So that's why we're saying to people, keep that date of the 3rd of March in mind. We are still working towards it, and I'd be confident we'll hit it.
Okay. The next question was, what reporting relationship will heads of discipline have under the new management structure?
Okay, so it's again, this is one of the key areas that we need to work out. But so as I'm interpreting this, a head of discipline, if we take a head of physiotherapy services based in the community, so physiotherapists working to that head at the moment have a professional reporting line to them, and they need that. We need them to have that in terms of having good governance over the services. So we have to retain that in some way, but also continue to have the governance or the management structure arranged around the CHNs and around the geography as well. So again, all I can say for the moment is that we will still have that professional reporting line and reporting relationship for sure, because we need it. But there will be an administrative management structure around that as well. And again, I'm just asking for people's patience as we work that through.
Will there be recruitment of new staff in 2025?
Well, definitely there will. I can say for sure there will be new staff, and the reason I can say that so categorically is because the service plan has been completed in draft format and submitted to the Department of Health. It's been passed by the HSE board. It's based on a letter of determination that came to us from the department, which provides for additional resources and additional services in 2025. So we can say definitively that there will be additional staff, and there will be additional staff in the West and in the Northwest as part of that. I think just to be absolutely clear, though, in my answer to that question, we will still be working within the pay number strategy, so people will have gotten a sense of how that's been working for the second half of 2024, and we will be working to a similar process, so as posts are vacated during 2025, we'll make the decision then to replace them, and that decision will be taken within the region as long as we continue to operate within our approved headcount, which we are currently.
How long will the social inclusion pilot programme for training centres in Mayo, Galway, Roscommon be allowed to run to see if it's successful before a final review? So
that's now quite a specific question. I'm just wondering, is there any one of the members of the regional management team that might feel better equipped to answer that one?
I think we'll have to come back on that, Tony, but I'll take it away and we'll come back on it. Yeah.
Okay, all right. Thanks, Anne.
A question regarding the expansion of services under mental health and CPD training opportunities under the new structure.
Yeah, and this might be one for Pat. I mean, one of the things that I've been very keen on as well is that that mental health services, while they're currently within community, even though I think it's best described as a very integrated service with both inpatient and community-based care as part of their way of working, and it's a well-established way of working. I think it's one of those areas that absolutely stands out as being one of the likely networks of care for sure as we go forward. And the second thing is that I think from a population health perspective, mental health is one of the areas that we would be really keen to make some significant improvements on over a 5-year or 10-year horizon. So I don't know, Pat, if you had any thoughts on that, but for me anyway, mental health absolutely stands out as being one of those areas for networks.
Yeah, no, I concur definitely, and it is clear, and and I suppose again, reiterating what you said, if you look at services that are integrated, hospital and community, it's fully integrated. I suppose what we need to do is integrate it with the other aspects of the community services and integrate between the acute mental health and the acute hospital services more. So I suppose it's an exemplar of an integrated patient pathway, but with how we integrate it with the wider structure, and absolutely. I mean, CPD, the whole importance of, of bringing our staff forward and how we push, there will be how we put that structures from across the region, there will be a chief academic officer to support structures, from education, and that we need to enhance that further.
What impact, be it short-term or long-term, will the implementation and integration of new structures have on the reporting structures for national service employees that happen to work in the West and North West area?
Well, there's a separate piece of work that's currently taking place. Well, it's not separate; it's part of the overall change that's been implemented, but it's a separate work stream under that, which looks at the role of people that are working in what's called the centre right now. So these are people that are in national, working in national functions. And you're quite right, Caroline, that lots of these people are located out in the regions, in places like in Merlin Park or in St. Connell's or in Manor Hamilton. You know, various locations around our own region as well. So. I think part of this, we have to let that process develop, you know, so there's a clear decision about what services are going to be become regionalised and what ones will remain in the centre. There is a kind of a framework that Bernard Gloucester is working to, which defines the role of the centre, and it is very, I mean, without going into it in detail, it's an oversight role rather than a delivery role. The expectation is that services and responsibility for delivery of services will be within the regions, and for me, within the IHAs within the regions, if you know what I mean. And so there is a change in the role of the centre of the HSE in that regard. So the time frame that I'm expecting that there'll be greater clarity on that before Christmas, and that the role of the centre come January and February, that we'll be progressing with that as well. And I think that there will be people that are currently working in roles currently in the centre that will be repointed to roles within the regions. I don't know, it's very difficult to say how many people that will be, but look, that's certainly something that we would welcome. And if a person happens to be physically located within our region, I think that just makes that transition easier.
Perfect. This is a question on community RNG vacancies and the fact that they feel that child development screens are being missed and the PHNs providing care for discharge don't meet the criteria of ICPOT and CIT. How do we get vacancies filled before RGN panels expire on the 31st of December?
And probably the simplest and honest answer to that is because I don't know all of the details, but I think it's fair to say to anybody that's, you know, to the person who put forward the question, is that any vacancy that arose since the 1st of January this year is likely to be approved, and that when I say approved by myself, because ultimately it has to come up as far as the region anyway to get sign off, but is likely to be approved for replacement, and therefore people can expect that they will be replaced. But if the vacancy arose prior to the 1st of January 2024, it's unlikely that they will be approved for filling. I have approved a very, very small number of posts in the last 6 months that fell outside of that time frame, and there were very specific reasons, but I can tell you that they've been really exceptional, and going forward it will be on the basis of that 1st of January cutoff.
There's a question here looking for information on plans for digital health services and opportunities available for staff looking to get into such fields.
So I think, I mean, as a general introductory statement, I would say I think we all have a sense that in order for us to achieve the kind of integration that we've described, that the enabler there is information, having the right information available to clinicians and to service providers at the right time when they're delivering services. But that's a kind of a general statement. If Vincent Jordan, who's on the call, may want to just give us his opinion or his views or his thoughts on it. What do you think, Vincent?
Yeah, so I think, Tony, it's clear that we're able to provide patient information to those staff that face off to the patients and try and come up with care plans and route them to services. That's absolutely where they can do their best job for our patients. So I think we've recognised the importance of a much improved digital environment, and clearly having the right staff to help us on that journey is crucial to that. There isn't currently any mechanisms to I guess, take people out of existing roles and into new digital roles, because the new digital roles that have been approved by the Department of Health for 2025, we haven't had any indications of which development posts will be coming to the region. We're hoping that will get resolved over the next period of weeks. So we do expect to be able to grow somewhat. How we collectively find a way to grow significantly and give opportunities for people that are skilled or want to grow in this area, I think we very welcome. We'd very much welcome staff that have got really good experience in healthcare to grow on the digital side. But at the moment, those pathways are still emerging. And I think that how we balance the provision of additional digital roles whilst keeping our services safe. That's something that we're all puzzling on right now, and it's not straightforward because the move to the regional environment has not come with a significant uplift in total WTEs, as we all know. We're all facing that challenge right now, but definitely we expect this to be a growth area.
We have a question here on the networks of care. Interested in hearing how the proposed network of care for older people and how it will be structured with existing operations will feed into it, including ICPOP, FFD, rehabilitation, acute care, home supports and NH care.
Yeah, I might take that. I see that. I think I see it as an immense opportunity, and that we need to sit down and, it's a key work stream to, the patient pathway, aligning all these services along the patient pathway, and what governance framework we can put in place with an older people's network to enable this, and I think it's a huge opportunity. And I know nationally, the national leadership and the older people at the NCAGL is very enthusiastic about such a model. Again, it would, it's not that it is the governance framework we can put around the delivery of an integrated model of care for the patient, and I suppose maybe because of my hospital background, I've emphasized very much it's the health, but it's also the social care of the community. I mean, it's a health and social care organization that we have. So, a lot of work to be done on defining it in more detail, and that'll involve representatives from the key stakeholders better involved in the delivery of care to older people.
In follow up, the next question links into that really. There's question is there any change to the existing MCANs?
No, I think, well, the yes and no. I suppose we don't want to lose anything. We had the strength and that we've gained from the structure we have, but it is hospital focused, so they all need to be recalibrated, redefined, and restructured to be regional. Some of them are more hospital centric than others, perioperative being an example, but others see there's huge potential in the children's network of how we, from an integrated perspective. So I think we won't lose what we gained, but they will be redefined, relaunched as regional networks of care going forward.
Question on whether the new structures will have any impact on existing national reporting structures.
They will. They already have, I guess. So maybe if I'm not exactly sure what the intention of the question is, but if I could explain it this way. So I report directly to Bernard Gloucester right now. And if you think about it previously, lots of people on the call probably know me previously as being the CEO of the Saleto Group. And when I was the CEO of the Saleto Group, I reported to a national director for hospital services. And she reported to the chief operating officer for the HSE, who in turn reported to the CEO of the HSE. So already those reporting relationships have changed and shifted, and I would say shifted for the better. So the gap between where services are delivered within the region and the CEO and the board of the HSE, that gap has narrowed quite significantly. We have also then within our region, we have changed reporting relationships as well. So for example, on the 1st of October, we established the IHA managers. 4 IHA managers were appointed across the region, and we changed immediately the reporting relationship of the hospital managers, for example, across our region. So they're now each reporting into an IHA manager. So that's also a change. And similarly, even in this interim period within the community, senior posts such as heads of service within the community who are continuing to deliver on their existing responsibilities, they are working with the IHA managers in their new roles as well. So I think already there's been quite significant change and more still to come with this final last step.
We have a number of questions, Tony, relating to when recruitment for replacement positions may commence, and also in relation to temporary contracts rolling over 4 years with unbroken terms of service, trying to work out when they may be regularised.
Okay, so on the replacement posts, it's the process that we have in place, just so that everybody kind of gets a sense of this, is that for each IHA manager, they know that each week on a Friday morning that I'm going to consider any requests to replace posts, and they come to me through a couple of different sources, but those decisions are made each Friday morning for the region. Then if you work backwards from that, each IHA manager has her own or his own structure in place within, including the hospitals and community, to consider and decide whether or not a post is to be replaced or recommended for replacement. And then that works back down to the individual service areas where managers have the opportunity to highlight the need to replace various posts. And so that's the structure that we've in place. It works on a weekly cycle. It's working reasonably well right now. We might need to look at extending that out to fortnightly cycles just for practical reasons. But I think the important message within that is that we are deciding to replace posts right now, and we are approving them, and we're recruiting to those replacements right now. And we will expect that to continue right throughout 2025, assuming that we continue to manage on the basis that we have done so far, which is within our allocated resource. So yeah, for sure, existing vacancies arising from the 1st of January 2024, we're working on those currently.
We have a question here asking, will staff be able to move easily between hospital and current community-based settings, subject to them being on transfer panels?
If we had Maria on the line, it'd be great. I don't know if we have though. But my understanding, my limited understanding of HR is that we do have transfer panels in place, but they're divided on the basis of CHO versus hospitals, and that if that is the case, then there is that impediment that's there. People then can apply for a job anywhere they like within the HSE once it's advertised, and compete for it if it's advertised on that basis. But if it's to be filled on the basis of a transfer panel, there are terms and conditions that are applying there. I would expect that to change. It is part of integration that if we want our services to be aligned, then it should be possible for staff to be able to move more freely between community and hospitals than they currently are. So I would expect that to change as the new structures emerge. If there's any senior HR person that wants to correct me now or give better information than that on the line, I'd appreciate it. That'd be great. Thank you.
I think Maria will be coming down on that. I'm just getting one of the team to unmute her, but while that's happening, we'll just go to another question and we'll come back to that once you've answered it, if that's okay, because we have a lot to go through. One of the questions here is, will previous group meetings be combined, for example, group IPC meetings for the acute and the community services?
Do you want to jump in on that one, Vincent? What's your own thinking about how we might manage that one?
So I think, Tony, to underpin everything that we're doing, we're definitely looking to make sure we're using the same solutions in all of our care settings. That obviously means that we need to align the governance, not just of the solutions, but actually the data that they generate. We've done a lot of work around one solution. It's a tool that's called ICNet, which we are trying to deploy in all of our care settings as appropriate. And we also have some other audit tools that are very helpful for infection prevention and control. I think, though, that governance from a clinical level and how the technology supports that, I think they do need to be joined up. And I think as part of the development of good governance, we will find ways to get that done in line with the networks of care as well. So I'm expecting that we will see a convergence of these things, and particularly with the technologies that underpin them. It's best where we have that information around patients' encounters and their conditions and their challenges shared to all people that are trying to make sure quality care is delivered.
I see Anne's hand is raised there, and do you want to come in on that one as well?
Yeah, just on the governance piece, we have had separate, infection prevention and control committees at hospital group level of the community, albeit we have cross membership and have had for the last year or two. But I definitely believe that we will be reshaping that and having a singular governance kind of structure across the region, I would anticipate. And I think that with the ICNet, as Vincent has outlined, I think there's a lot we can do in terms of, managing infection and understanding, why infection rates occur, etc., collectively in an integrated way, looking at, from the community in and back out again. So I definitely believe that our existing governance structures will be, re-looked at and reformed in the context of the regions and the health areas.
We have a number of questions coming in relation to where health and well-being and health and promotion with public health, how that'll interact and where that sits.
So again, this is one that isn't decided yet, that we need to work out. But I do think that the discussion has moved on quite a bit. So maybe I can explain what I mean by that. I think there's no question that there's a health and wellbeing, there's an element of the health and wellbeing service that must remain operational, must be part of the community healthcare networks, and we must be actively involved in prevention and health promotion at that level, at that operational service delivery level within the CHNs. There is a broader kind of a population health piece as well, and so we do have the regional director of population health on our management team, Dr. Anya McNamara. And that's really important, that we kind of maintain that focus on not just improving or delivering healthcare, but that we're actually improving health as well of the population. So, I think the answer to the question is when we get to the other side of the 3rd of March, that hopefully we will see health and wellbeing in both of those settings in a very operational way, delivering day by day, hand in hand with primary care services and others in the community. But also operating at quite a strategic level as well, making sure that we keep our eye on that bigger picture, that longer term gain for the population.
I just want to check, Maria, you're there now and you should be able to speak if there was something you wanted to add to the previous question.
Yeah, that's great. Thanks, Caroline. Yeah, just there were two things I just wanted to pick up. Adding to what Tony has said, we have signalled to the staff representative bodies that we want to discuss with them a staff transfer policy or mobility policy for the region. So hopefully that engagement will progress over the coming weeks and months as well. There are some existing national transfer panels that are in place, but in the context of the new health regions, we do want to take the opportunity to discuss that regionally as well with our union colleagues. And then there was a question in relation to entitlements and contract entitlements as well. So if any staff member feels that they have an entitlement, they can write directly to their local HR department in the first instance. There are particular rule sets and HR circulars which can help determine whether someone has an entitlement to a permanent contract. So I would encourage any staff member who have a query on their individual contract, please do reach out to us directly and we'll deal with those promptly and come back to you.
Thanks, Maria. We have a question here on whether some patients will continue to access hospital services in Altnagalvin and Ballykelly, or will the referrals go to Galway in future? And will some patients from the Northwest be referred to Dublin hospitals for treatment?
So maybe Anne and Pat might both have something to say on this one. Did you want to come in first, Pat, or I have a view as well? But
I suppose the access to Ballykelly was through the NTPF. It's a private, it's a temporary. And my objective is that we develop our services, that we can provide the service within the region and that we don't need to outsource it. There is specific arrangements with Altnagalvin for primary PCI, which will continue, which is for patients presenting with a heart attack in Donegal, that they're transferred to Altnagalvin. And that's due to the adjacency and the time critical nature of it. And that will continue. That's a long-term relationship. But, we aim... in the region.
The radiotherapy service with Altnagalvin will also continue for North Donegal, because obviously that's really, that proximity for that continued period of treatment is really important as well. So they will definitely continue.
Yeah, and we are open to exploring other relationships. It is, where the adjacency and the distance that people in Donegal have to travel is a very real factor, and that where we have explored other options as well, and will do. I see Dermot coming in there.
Yeah. Do you want to come in, Dermot? You're on mute, Dermot.
Yeah, I've come off there, Tony, thanks. And I don't know if I'm getting in ahead of you, but just to say, as IHA manager with responsibility for Donegal, all and every service development will be considered across any jurisdiction for the people of Donegal, because if we think travelling 3.5 hours or 4 hours is a benefit, I don't think many people in Donegal will be very happy if they were told their services were being, or in Dublin were being told their services were being provided in Cork. So yes, of course, that's part of what our role and function will be, is to expand the services in Donegal for the people who live and reside in Donegal.
And the only point that I was going to add at that is that one of the benefits of the hospital group was that in bringing and knitting hospitals together, is that it created better pathways, I suppose, for patients to travel between, for example, Letterkenny, Sligo, Mayo, and Galway, to receive appropriate service in the appropriate location. It doesn't solve the problem of geography, but it does help with access in other respects, and it ensures that within the region that you're building up a layer or a level of expertise and a level of competency across a range of services. And we've made good progress on that, I think, over the last 10 years, but I think there's still further progress to be made, particularly in respect of some key services, and actually, particularly probably in respect of the Northwest. I think there are still some referral pathways to the East that would be better served actually within the region if we had the resource to do it. Am I saying that correctly, Andy, I think, or is that the best way to put it?
No, absolutely. And also, I suppose, just in the context, if you're talking about hospital services, there's a piece of work underway, say, for Letterkenny Hospital in terms of its service profile going forward. And we know there are areas that need to be developed, as I'm sure Dermot will, also say, with, in terms of the community services. So there is work and there are developments that we do need to do in the area, but we also have developed very strong pathways, both with Altnagelvin and also, say, within our region. And we also do use the private hospital services for some activity that might not get, for long waiters, etc., that actually help access. So I suppose it's really about improving access for patients in the best possible way.
Okay, the next question we have here is, when will the framework that was accepted by the steering group be shared?
So I think, and apologies if I haven't done this now, but I think I have already shared it out with the regional health area management team, and it's open then for the regional health area management team to share it as widely as you want thereafter. If it hasn't gone out from my office yet, it certainly will go out after this today, Caroline, and people can expect to see it after that. It was only Monday when it was accepted, so it's not like it's been sitting there for a long time. It hasn't.
Next, currently Mayo and Roscommon are aligned, but within the new IHA structure, Roscommon will join Galway. When do you envisage this happening? And this is from a dietetics manager, in case that has an aspect.
Okay. Do you want to have a go, Anne?
Well, the 3rd of March was listed earlier, so I think people need to keep that on their agenda. So we have to work out the detail of how any realignment will occur. We're working very much, in the interim arrangement while we're figuring out how that will happen. As in a lot of the services, the natural movement of patients is between Roscommon and Galway on the hospital side, but also, on some of the other services in terms of ICPOP, etc. So the detail has to be, as part of the work that we're doing at the moment. And part of the work we're doing is looking at the lowest unit, as Tony indicated earlier, the lowest level, and how services are delivered in that geographical patch and how they can be delivered. So there will be some realignment, but the date we're working towards is the 3rd of March, but it is a work in progress.
This, I think, is for you, Pat, in your piece. It says, I think the idea of avoiding silo design is worthy, but within community children's services in particular, there are very clear silos already established. Primary care services, disability services, mental health services are all separate services with different referral criteria. I am concerned that integrated care will be more focused on adult services than on children's services.
No, I think that's a very, very good example. We're talking about integration of services, not just between the hospital and community, but within the community as well. And I suppose the traditional pillars that we've had led to a degree of silo. And I think what we need to get down to is at the operational level, what is the population, the areas currently provided by the CHNs, but looking at the wider service delivered there at the community health area, how we can ensure that services are integrated around a child rather than being siloed into mental health, disability, primary care, etc. That it's an integrated service, and that's where the gain in having a population-based delivery of service and having a fully integration. So all of that is up for discussion and engagement, and see how we can make it as patient-centered or service user-centered as possible.
The next one's also relating to networks of care, wondering that while they provide general governance of service or only clinical governance, will there be a clinical lead and a management lead in each network?
Yeah, I suppose you.
Yeah.
Sorry,
you go for
Tony.
it, Pat,
You go first, actually. There.
No, I was going to say it's probably one for you, Pat. But yeah, you go for it, Pat. Yeah.
Well, I suppose this clinical governance, it's governance in the widest stream. The clinical governance is focused on the quality, safety, but it's the two of them are interrelated, clinical and the traditional managerial governance, and so it is focused on on setting the clinical strategy, and actually maybe to move it a bit broader, the care strategy. It isn't all clinical, and I mean disability is care, large components of older people, it's care, children, it's care. So and that's why we're calling it networks of care, not clinical networks. How we have a consistent strategy, how the networks support the quality and safety and help in providing the assurance. But it doesn't undermine the structures that there is going to be an immediate line manager reporting up to the IHA manager, reporting up to the REO, and it's the structures that enable that the delivery of the service, the quality and safety, and helping in the assurance process. So it's a collaborative leadership rather than one undermining or overriding the other.
Will existing pathways for patients being referred from Donegal to Dublin hospitals for specialities such as neurosurgery be affected?
If I could maybe just answer this generally, and again, Pat might want to come in then maybe more specifically, but generally, I suppose that I think the guiding principle that we always work to is to take decisions about on the basis of what makes best sense for patients, so where can they receive the best care. I know that sounds very simplistic, but it's really important because in the context of us trying to be regionally self-sufficient insofar as it's possible to do that while it's in the interest of patients, that's what we're aiming for. And I do think there's still a good bit of work for us to do in that. There is more that we can do within our region that would be good for patients, and but obviously it will be resource dependent. But there will always be some services that are delivered at national level in national centres, and the trick will be to get that balance right. To be as regionally self-sufficient as we can, while remembering that it's in our patients' interest sometimes to refer them to a national centre. So, Pat, you probably can answer better than that. But...
No, I think just exactly as you said, Tony. There is national centres in Dublin delivering national services. Some of the rare cancer specialties are very much nationally led and should be, and appropriately so. And neurosurgery again delivered from Beaumont, and where there is services, we're not having the region doesn't mean to say that pre-existing pathways, relationships immediately have to stop or be undermined in any way. But I think what we need to look at, and I think increasingly, that if they can and are appropriate to be delivered within the region, how we enable that rather than changing, rather than directing changes in pathways. But there is significant numbers of. They're small volume, but they're specialist centres nationally that will continue to function and that we will work with the national system to ensure that those pathways work as smoothly as possible.
Pat, I know that you have to leave, so I'm going to throw a few MCAN questions at you quickly before you do. There's a few one saying that how can we be sure that children's services will not be forgotten? And linked to that, there's a follow-up one saying, I strongly believe that children should have a separate MCAN in order to have a fully integrated children's health service between acutes and all aspects of community care, inclusive of a strong preventative focus. Two more and then you can answer them. What is the role of the clinical programmes in networks of care, e.g. older people? And will networks of care have a budget? And they're just the one.
Well, firstly, the children's absolutely, and I think one of the previous questions we answered is about the kind of the siloed, community based. So we already have in Saleton, and the hospital have a clinical lead for paediatrics, and we've a director of nursing in paediatrics. I see that there is significant scope to have a network of care for children. It effectively functions separately, even though it's under the umbrella of women's and children's currently. So, these networks will share some of the support resources around them around quality and safety, the business management, general management support. They can work collaboratively with the shared, but it functions separately in that regard. The national models of care, absolutely. The national clinical programs, their job is to develop models of care for us to implement and to be there to help support us in that. And we've been working with them in the design of networks of care from a national point of view. But their role is, and and I would see that the leadership we develop in the networks at a regional level should be core members of the future national leadership team in developing the future models of care. And the last thing is, as regards budgets, I think, the commissioning of new services, etc., is something that traditionally has been very centralized, and is something that will need to be, I suppose, reallocated to the region, consistent with the national strategic objectives. And I suppose Tony might want to expand on that a bit. So I may have talked myself into a riddle there a bit.
No, actually, Pat, I was reading ahead to some of the questions that were in place, but I think one of the pieces about the national clinical programs is that there has been probably too many of them for us to maybe to really get focused in on ones that can be implemented. So there has been a difficulty from that point of view. I think what we'll see, though, is that with the review that's currently being finished out now by Colm Henry's office, is that there'll be a strong alignment between, as Pat said, the networks of care and the national clinical programs. That'll make it easier for us to follow that line through, and it'll certainly make it easier, I think, when it comes to service planning and for the disbursement of funding, so I think that that will help as well. And there was a question about budget, and again, I know that people. I understand where the question comes from. Where if we look back at the experience of the MCANs in the hospital group, and this isn't the be all or end all, but it is an important experience to reflect back on, that the MCANs played a very important role in terms of attracting new money through the service planning process and estimates processes, and then in helping hospitals in the hospital group to decide how that money was dispersed and where it should be located and where it should be located first, and that helped with the delivery of services, development of services on individual sites. And I would see the same type of strategic role being important as part of the networks of care going forward, and I think that's probably the best way to explain it. I think that's one of the key roles that the MCANs played and that the networks can play.
And I'll just go back to as we receive them. So will live panels be used for new recruitment of posts?
Maria, we're going to turn to yourself on this one.
Yeah, and there'll probably be a combination of live panels and perhaps even a requirement to establish new panels. So it would really be on a case-by-case basis. So recruitment is continuing at the moment, as Tony has said, and panels are being formed all of the time. So it's likely will be a combination of both.
And
how will it help? Sorry,
just in case, Caroline, that question relates to the 3 posts that I referred to on the regional management team. There are particular how would you call it, recruitment arrangements associated with those posts because of the way in which the posts are being created. So there, for example, there's a limited pool or there's a confined pool in respect to the regional clinical director or regional director of nursing and midwifery post, and similarly there will be other restrictions in respect of some of the other posts at that level too.
Okay. How will health inequalities be incorporated into a population-based approach to service planning, both within hospitals and community-wide?
So this is definitely one for our regional director of public health, and there's absolutely no doubt about it that that when you look across our region, the Western Seaboard in particular has has a marked levels of deprivations relative to the rest of the country, particularly along Western Mayo, Western Donegal, west of Galway, and of course we also have the inhabited offshore islands as well. So health inequalities are quite significant at a deprivation level. I think even this week we've seen how people's experience of the health services, but their cancer services varies as well in terms of the geography or the location that they're coming from. So what we're promised, and I know this has been worked out within the Department of Health, is that there will be a population-based approach to the allocation of resources. Now, it's a very complicated process when you consider where we're starting from, but the Department of Health are working on it currently, and it's probably something then that will have to be rolled out over time. And the early indicators are that they will use a small number of indicators to decide on how those resources will be allocated, and one of them is obviously the size of the population. The second one, which is an important one for us, is the dispersal, which Pat referred to earlier on, and the third one is one that I just referred to there, which is around material deprivation. So my hope would be that this will feed into the piece that I said earlier on about our role being not just in the delivery of healthcare, but also in improving the health of the population. So my hope is that that structure will help to support that.
Question here on will there be a regional chief academic officer?
So in a way, it's an easy question to answer because the answer is yes. We have a chief academic officer within the hospital group currently. Maybe not everybody would be familiar with that role, but we have a chief academic officer within the hospital group currently, and that has proven to be a really important link between the hospital group and the university for sure, and very important in terms of development of CPD, which was referred to earlier on, for a number of different grades of staff. So will there be one at regional level? Yes, is my short answer to that, and I don't mind somebody reminding me that I said yes in a few months' time.
So this question then is an integrated inclusion health structure being explored with social inclusion to deliver quality care and outcomes to marginalised groups like homeless, those with substance abuse issues and migrant health? These populations have increased on a large scale in recent years.
So I don't know if any of the IHA managers want to have a go at this. I don't know, Dermot, if it's something that maybe you would have a view on, or maybe John Fitz is also on the call. You might want to have a go at.
I'll leave it to John.
Yeah.
I think, Tony, it's something, sorry, that we are going to have to look at. We do have a much increased population within our region. I'm not sure that we're there yet in terms of it. I suppose people will be aware that over the last few years there were nationally some teams, you know, that we had hoped would be appointed to support the, you know, the social inclusion kind of aspect of service delivery. But obviously that they haven't materialised because of, I suppose, where we've come from in the last year or two. So at the moment, you know, they're being supported through all of the pillars within the community services as well as through the hospital services, but looking at a coordinated approach and a strategy for it certainly is something that we're going to have to look at. But I don't, you know, at this point in time, there are so many other elements of the structures and you know, how services are going to be delivered, that we're not there. I don't know whether John wants to maybe add to that.
No, and look, I think you've given as much as I could bring to it at the moment.
The one thing that does strike me, I met with some of the social inclusion leads earlier on this week in a meeting that was organised through the Department of Health, and one of the things that's really striking in that context when you sit in that room is the level of integration that already exists within the social inclusion service, particularly with services outside of health. For example, their linkage with An Garda Síochána and their linkages with local authorities and with other groups that are really important from a health perspective, you know. So there's a bit for I think for all of us to learn from that as well, and as Anne said, lots more work for us to do on that front for sure.
And this one goes back to vacancies, and just a question: would there not be merit in reviewing vacancies that arise and determining whether the priority is filling posts that became vacant after the 1st of January 24 or posts that were quotes lost if vacant on the 31st of December 23?
Yeah, so the short answer to that is yes. Actually, there's a lot of merit in it, for sure. It's not as easy as you might think, though, to achieve it, you know, because to some extent, you know, the location of the post has to be taken into account, and also the type of post, you know. So, you know, if we take a clerical officer would carry a particular salary, you know, would the job that we're proposing to replace that with, you know, would it carry the same salary and so on? So it's not as straightforward, but yes is the very short answer to it. And the second, if I'm to give it a fuller answer, I'd say yes, it's also possible. So it is open to me as REO to make a decision to convert a post from whatever it is currently to something else that we would determine is more important at that time or something like that. And the way that I would do that is, you know, again, you know, that if a post becomes vacant at a particular service level, it has to be recommended for filling through the line, up to the IHA managers and up to myself. If it doesn't go through, if it isn't recommended in that way, it doesn't, it just doesn't get approved, and then I'm the final line of approval. But it is open to me to convert jobs over in that way, and yes, it's the short answer to the question that's been asked.
Question: has there been any agreement on the final version of the reassignment principles, which is the subject of discussion at the national jump? When will it be made available to staff?
I'm not sure, Marie, if this is an area that you have any
I think it is.
on.
Yeah, I do think it is nearing completion, is my understanding, Tony. So I know that the discussions are very advanced. So we'll get a further update on that, Caroline, and send that back.
Will the quality and improvement function for clinical governance be integrated within each of the networks of care or remain site area based?
So I think Pat is probably off the call, but just so there are some, we have absolute clarity on some aspects of this. So at the moment, what we have said is that quality and patient safety, or QSSI within the community, that they would that their reporting line would be through to the regional clinical director. So that much is established, and we have that established on the interim period as well. So this period from the 1st of October to the 3rd of March. So that is the current arrangement, and it's important that we would have that absolute clarity for sure. One of the key roles of the networks of care that Pat described earlier on is around quality and patient safety, or quality and safety as it's described within the community. So that's the work that's happening at the moment to see, can we integrate that within the networks and allow them to continue to take a lead in respect of quality and patient safety, as in the way that the MCANs took a lead in that area within the hospital group. And so, but then I think, and hopefully this will help to explain this a little bit better as well. What I would see though is that we will have a lead for quality and patient safety then within the region, and there will be IHA based leads as well. That it will reach out into the integrated health areas and work back up to the regional structure in that way.
Address some of these before, Tony, but we're just going through the questions as they come in. So, where long-standing essential frontline services have been cut as a consequence of posts temporarily vacant being decommissioned, is there any plan to restore over time these services back to the baseline level of service provision, or will new posts only go for new service provision?
So I'm going to answer this question honestly, and this is one of the ones that I said at the very start. This is what I mean by this. There's no point in me sort of giving a question that makes somebody feel a bit better about where they're at. First of all, we know that there have been vacancies in individual services, and that particularly where you've got a small team and somebody left in 2023, and now that post hasn't been replaced, that leaves a gap. It leaves a gap both for colleagues that are trying to deliver service, but also for patients or service users as well. And we get that. And the only way that you can deal with that is deal with it over time by reorganizing how work is delivered or restructuring how it's delivered. It is not proposed that we would go back to fill those vacancies in order to address that. It's not proposed that we would do that, and I don't have the capacity to do that anyway, and it's important that I would say that. Absolutely, when we get new service approvals, as we will do in 2025 and we have done in 2024, through the service plan and the estimates process, we will be filling those posts, and that will help with new service provision, but it won't deal with the historic vacancies that are referred to in this one. And I suppose it is important that I would also say, though, in this context, that while I absolutely acknowledge that there is an impact on service from these vacancies, we also all need to acknowledge that there has been a general significant increase in the levels of staffing across the health services over the last 12 months, but also over the last 2 years. And if you go back 3 years, and certainly back as far as COVID, the increases in staffing have been quite significant over that time. And the demands on our service have grown, and our ability to meet those demands, that's also grown as well. But I think I hope I've answered that question as honestly as I can anyway.
So another question just in relation to vacancies, I suppose, in contracts. Why are we circulating info repackages and relocation allowances for recruitment of overseas candidates when we are failing to retain existing staff in specified purpose contracts of only 3 months and losing many wonderful staff from community services to new permanent posts, leaving services unable to cope with the demand? Many of my temp staff are backfilling long-term seconded posts, yet only getting 3 monthly contracts.
I'm certain Maria is going to want to comment on this one. So yeah.
Yeah, so I suppose in relation to international recruitment, that is part of our approach to recruiting to various vacancies across the organisation. So it is one of our strands. So in addition to what we would do locally and regionally, that is another strand of recruitment. And we have used that successfully in some areas where we've been very challenged and tried to fill vacancies through the local workforce supply. So that's just in relation to the first piece. In relation to the second piece, absolutely accept that there are a number of staff at the moment who have been impacted by the 3 monthly contract arrangements that were brought in earlier this year. We hope as we move into the new year that we will be able to look at that in the context of the health region and whether we can give greater certainty to some of those staff. So that is getting active attention at the moment, and we do have a lot of staff across the organisation in that position. So hopefully in the new year we will be able to give some further clarity to staff around longer opportunities that might be available in our services where posts are approved.
Perfect. Will the HCPs be supported to complete the Making Every Contact Count training in the new structures? This is a key element of the integrated care programme for the prevention and management of chronic disease and provides an excellent example to extend the principles of integration for the rollout of the prevention agenda across the entire health services in the West Northwest.
So again, it's a kind of an easy question for me to answer. The answer is absolutely yes. Health promotion and prevention at the operational level, as I described earlier on, is really, really important. And in order for us to kind of to demonstrate that its importance, we do have to give staff, our own HSE staff, but other staff as well, the opportunities to train and to skill up so that they can deliver on it. Yeah, absolutely.
How is it planned to interface the network of care for children with the National Service Improvement Programme for Children's Services? Significant work and actions being delivered with a regional engagement workshop to be held in Q1 25. The Service Improvement Programme Board is chaired by David Walsh.
So I think the role of the National Service Improvement Programme Board will be examined, I think, in the new year. I think there will be, if we start at the very top, within the Department of Health, disability is now a separate stream, and that's going to be that's going to continue within international HSE central structure, but also into the regional structures as well, where we will have a regional lead for disability services. So what I would envisage though is that it's likely that we will have a service improvement board, if we call it that, or a service improvement team within the region that is feeding up to a national structure. Who it's chaired by going forward, I don't know. I think it's unlikely to be David into the long term, but I would imagine there will be a national structure, yeah.
The replacement of posts should be based on need rather than a set time deadline. Where is the patient and service needs considered in this process?
So I mean, I don't think it's hard to disagree with it, except that that what we also need to do, and it's an unfortunate reality that that we absolutely do have to do the very best that we can to meet the needs of the population that we're serving, but it's within the resources that are allocated to us. The difficulty that led us to the moratorium and recruitment was that we exceeded the level of resources that were allocated to us across the health services generally, and not by a small amount, not by a marginal amount, but by quite a significant amount. So that did have to be corrected. That's where it came out of. Right now, where we're at is we are working just within the allocated resource. I think that's a reasonable ask of the taxpayer to put on me, that I do the very best that I can with the resources that are allocated to us. So while I agree in principle, I think the reality, real life, is that you must work within the allocated resource.
Will staff in current THAs less than 4 years be considered for redeployment at their THA grade, or will they be returned to substantive posts if the post they are in is removed in the new structure?
It's quite a technical question, Maria. I don't know if you want to have a go at it.
Yeah, well, I suppose there'll be a number of kind of considerations around the extension of THAs. So THAs will be in place for various reasons. So each will be dealt with on an individual basis. So some THAs may be in to cover a particular vacancy. They might be in to cover a maternity leave, a career break, as a comment, or whatever it might be. So I suppose each THA will have to be considered on its own individual basis, and a decision made then in the context of the new structures as to what the future of those posts are. But again, if there are staff who are impacted at the moment who are concerned about a continuation of their THA, again, I would encourage you to link in with your local HR department, and we'll engage directly on that with you.
If I could make a general point on that one, Caroline, it's just to say that that, as I've said on a couple of occasions, we're currently just within our approved staffing level for the region. That's where we should be, and that's where I intend for us to stay. On top of that, we'll add in the new approved posts that we get under the service plan for 2025, and that'll be part of it. For people that are in management roles, and I'm conscious that that we are changing the management structure. So people maybe are concerned. Then what will that mean for me? I mean, in general terms, we are working on the basis that the existing staff that we have in management roles within the within the region, that's the number of of roles that we're going to work to. We're not going to increase it, but we're not going to decrease it either. I mean, my view is that that people across the region are working hard to deliver the services that we deliver, and we need all of those people that we currently have.
This relates to the disability services. In the absence of a regional disability lead job spec, how is it proposed to design disability service structures and a disability network of care ready for implementation on the 3rd of March 25?
It'd be a lot better if we had a regional disability lead for sure, but it does mean, Edel, and I'm kind of addressing you directly, I hope you don't mind, but it means then that we're leaning on people like yourself who have expertise and a long experience in this area to try and inform the way that we're going forward. But look, I would much prefer if we had the regional disability post filled at this point, but we don't, and we just have to work around that.
This is to do with the CHN Plus. So with teams moving to the CHN Plus model, will staff bases and locations move to said CHN area, or will they stay in their current base?
Very, very difficult to say, Caroline, but because and it's unlikely to be the same in every case, I would say. But I think the important thing for people to understand is that if we build our structures around the CHNs, and we will be, that is the basic building block that we'll be working from. That we will be looking for staff to be located in those CHNs. It won't be practical or possible for people to be living remotely from the areas where they're working. But that's a general kind of a position. What that means for individual staff. We just have to work that through.
What is the vision for educational preparation with regards to staff who can work across the domains of both acute, long-term and community services? Will staff still work separately in the respective domains and have capacity and competence to work across, or have capability and competence to work across all areas?
I'm not sure if anybody else has an insight into this one.
Well, just to comment, I suppose, in the chronic disease programme and ICPOP, we have staff who are working across community and hospital services as it stands. It wasn't without its challenges in terms of clarifying the governance at each point of where somebody's working, whether they're working in an integrated hub in the community or in an OPD in the hospital or wherever. So we have a precedence for people working across services, if that's what the question was. And I suppose it's really building on that. And we did have to do a significant piece of work in relation to the governance, the professional lines, the actual managerial governance, etc. But we already have a precedence for consultants, CNSs, and some of our, our HSCPs working across hospitals and community as it stands, and it's building on that and building on the learning.
Are the existing and emerging intersectoral collaborations regarding recovery, mental health promotion and protection between primary care mental health services and health promotion preemptive?
It depends on what you mean by preemptive, Donal, I would say. I do think that there are some of the things that we've seen, some of the things that I've seen in mental health and particularly initiatives that have developed in the West and the Northwest over the last 5 to 10 years that I wouldn't have been awfully familiar with. But they certainly have demonstrated to me how important areas like health promotion are in respect of mental health. And they've also demonstrated to me how we can integrate mental health services with broader primary care and with other services as well. So if you mean preemptive in the sense that they may be showing us the way of how things can be done, I would definitely agree with you on that front for sure. And I think the trick for us would be to look at that with an open mind and say, could that be adapted more broadly across the region, or could it be adapted more broadly across other services as well? I think there's a lot that we can learn from how the mental health services have adapted over the last couple of years.
To what extent will there be a strategic focus on waste reduction between silos and lean digital transformation?
I'm feeling this is one for you, Vincent.
Yeah, so I think, Pete, it's a really good question. I think, to be honest, a lot of this is part of our individual accountabilities and responsibilities in our roles anyway, where we see waste and we see that can be avoided to ensure adding value to patients. We should do our best to surface that and find ways to address it. So I think that's a normal part of it. I think certainly doing joined up care now in a new way that Sláintecare is enabling and the establishment of the region, I think that might help us find other opportunities to ensure that everything we do is adding value to our patients. We know that better digital tools are a key part of that, but we know that that's also constrained in several ways. We've already spoken about how do we grow our capacity to do that, and that's a challenge that we all need to work on. How do we also make sure we get the right tools, because some of the decision making around the digital capabilities that we can deploy are currently held by people outside of the region. So I think we need to work on this. I think certainly everything that we're doing so far is about this concept of adding value to the patient within a context of the resources we have available, that they're safe, that they're highly reliable. I mean, they're really the principles that will guide us. And I think there's definitely a role about waste elimination and digital transformation in achieving those objectives.
I think Anne's hand is up on this one as well, Anne.
Yeah, just to add to that, really, I suppose we would hope, as Vincent says, when the tools are available, when we can expand them out, when we actually can get to the point where we have systems where the relevant clinician can see relevant data, in relation to a patient or service user, wherever they are, in the community or in the hospital or in the hub. I think that will eliminate duplication, particularly in relation to diagnostics and other tests and laboratory tests, etc., where I think at the moment, due to that lack of shared data relating to a patient by the relevant clinical staff when they're, interacting with the patient, I think leads to duplication, and that obviously leads to, maybe it's waste, really, I suppose. And we would hope that as we become more integrated and as we are working in a more integrated way, that certainly that aspect could certainly be improved upon, and having that kind of, that sight of the relevant information relating to a patient, regardless of where the clinician is or interacting with the patient, would be, that's where we want to get to, I suppose.
We have a few more, so we will try and get through all of them. What is the vision for staff to have capability to effectively work with populations as aggregates? Will staff be prepared to profile communities, identify health needs, and how will the population needs be managed with regards to planning for future services?
So I think this is really where, sorry, Vincent, did you want to come in on this one, or?
Well, Tony, I'm happy to give it a go, and if I've missed,
go for it, please, sir.
So I think to be fair, our public health colleagues with Anya McNamara has developed some really valuable population profiles already. I've had a couple of conversations with Anya about how we can improve the information that's available to the public health teams, and actually that gives us some of this information in aggregate and how that can be planned, in line with the principles of Sláintecare at a local area level, the closest to the patient as possible. We absolutely need to try and do that. We need to do that in a way that protects our patients' information as well. So it's not something that we can just kind of have a free-for-all on, because we really do have to protect our patients' privacy, and so getting the right granularity and balance there, but certainly making sure that our service planning decisions are informed by data, and already some of the profiling that Anya has pulled together and is actually available to all of us on the HSE website. That's incredibly helpful already, but we do expect to grow that.
John's hands is raised as well.
Yeah, Tony, just to come in on that as well, in terms of there is people may be aware it's a population-based steering group nationally, but part of the work, and I'm on that from an IHA perspective, but part of the work of that now is to establish an operational delivery working group at a national level, which will transfer down to a regional level. And that will be putting together a health profile for the region. And that work is commenced with a view to kind of January onwards. So people will hear more about that in the coming months.
When will a West Northwest Regional Assessment of Need process or office under the Disability Act 2005 be established, as CHOs no longer have legal standing as the unit of operation?
So I guess I will come back to the answer at the very end, but important to remember that, first of all, the legal entity under which we all operate is the HSE. So the CHOs, as they were an administrative structure within that legal entity, and then the authority within the CHOs to conduct assessment of needs, and authority in respect of other things, then we're subject of these delegation orders. So delegation order that says that Tony Canavan is responsible for X, Y, Z, and so on, and so that remains remains in place. It has been changed and shifted to some extent with the establishment of the REO post, and then the standing down of the chief officer post and the standing up of the IHA manager post. So those delegations have shifted to manage that. So now the answer to your question, I would say, Del, is that I would say we're probably looking at deciding on that during 2025. It won't be by the 3rd of March for sure, but deciding on it during 2025 and then implementing it thereafter. A single regional assessment of need process or office may be the right thing to do, or it may make sense to, for a variety of reasons, to have more than one location through which it's managed. So I would say that decision will be taken during 2025 with the idea of it being implemented before the end of the year.
And what does the proposed flatter management structure look like from head of service down?
So it's a really good question, Emma. I think first of all, there's a couple of things that I would say. One of them is what I said earlier on, that there shouldn't be any layer of management within our structure that doesn't add clear value for patients or service users. Sometimes, people will describe value in terms of, it facilitates management or it assists with the organization and structure. I'm saying, no, the only criterion that should be used when we're deciding on using or having a layer of management is, does it add benefit to patients or service users? That's the first thing. Specifically then, what it might mean for heads of service, again, going back to the point that I made earlier on, we have a number of heads of service currently working within the system. After the 3rd of March, I would expect us to have the same number. I don't expect that number to grow, and I don't expect it to reduce. I think there's a significant level of service responsibility in each of our regions that requires to have those senior people in order to be able to make sure that we deliver those safely. Flatter in the sense then, though, of the head of service reporting directly to the IHA manager, and that the people that are reporting to the head of service would have direct responsibility then for service delivery. So, for example, it may be that we group a number of CHNs together with a manager over them, and that person is reporting to the head of service. We will absolutely be bringing the regulated services together, such as the older people's residential services, disability services, and the approved centres under the mental health. We'll be bringing those together, and almost certainly they will be grouped together under a head of service, reflecting the fact that there's an additional responsibility that goes with those roles, and the authority then associated with the head of service comes with that. So I hope that goes some way of explaining it. I think it is fair to say that when we look across our own region, we will see slight differences in areas where we have relatively small IHAs. That connectivity between the head of service and the direct connectivity between the head of service and where services are delivered will be shorter. The distance will be shorter. In bigger areas like Galway and Roscommon, there might be a need for us to put a person in between that.
We just have a few left, so if you just bear with us, we will try to get to all of them if that's okay. There's about, I think, 3 more to answer, or 4. Tony, are there any changes regarding Section 38, Section 39 service functions or structures?
Yes, but not significant in the sense that, well, I shouldn't say not significant, because they may be very significant depending on where you're sitting and what your perspective is. But yes, there are changes. So one of them I would describe as follows. When I talk to the 4 IHA managers in our region, I say, you are responsible operationally for everything that's happening in your area. And that includes the services that are currently provided by Section 38s and 39s within the area. They, of course, will be working with, for example, the regional lead for disability services and others as well in respect of that. But I think that is a slight shift, or there's a shift in terms of that fundamental relationship, and that's important. So that's a change. The second thing that I would say that I absolutely was, I suppose, alerted to at the end of last week, and it was something maybe I suppose I should have been maybe more aware of, but the need for us to mind that relationship between ourselves and Section 38 and 39s very, very closely, and the importance of Section 38 and the delivery of particular services across our region, across the country as well, but across our region. So I would hope that one of the other changes as well that will be facilitated by the IHA management structure is that it will be possible to partner more effectively with some of these organisations so that they are more knitted into the delivery service than they currently are.
Okay. Will CDM and ICPOP functions and function and operate as part of the CHN Plus?
I wonder, Anne or Dermot, do you want to have a go at that?
Well, I just want to, I suppose, for the chronic disease and ICPOP, they work across a few networks or a few CHNs. There won't be one in every CHN. So it'll be more the community healthcare area in terms of how we group CHNs. So at the moment, in my geography, people will know there's an integrated hub in Galway, there's one in Ballinasloe, and there's one in Mary's area in Castlebar. So it's, they'll be working across a few CHNs. That's the way they're working currently, and we wouldn't see that changing in the short term. I don't know whether Dermot wants to comment.
No, that'll be the right interpretation, and like they already run outreach clinics across the areas, particularly in Donegal. So yeah, that'll be centralised, but providing a service to the CHNs as needed.
Folks, we have a few comments. One of them relates back to the THAs, and on that one, I'll just, Maria, send it directly to you because it's a specific piece, and we might deal with that offline and see if we can move it. And then the comments really relate to the fact that frontline services are most impacted by the recruitment piece in play at the minute, and by the roles that are being filled are more in management, and there's a call that more will be done to fill these across community services and other frontline services.
Yeah, look, I take that on board. The only one kind of thing that I just want to pick up on the comment there, I hope I didn't use the term overstaffing, and if I did, I apologise if I did, because I mean, I want to be very clear. I think the staff that we have currently working across the region, across all of our services, my experience has been that they're extremely busy, and that there is significant unmet need. And if we had more people, we could deliver more service. And so I think that's absolutely true almost across the whole region in respect of all of the services that we provide. So I don't believe that we're overstaffed in any sense. What I do believe, though, is that there is a limit to what can be afforded, and for sure in 2023 we exceeded that limit, and we exceeded that limit across a range of services. It wasn't just in any one location or in any one service, so we exceeded that limit. And so I believe that it is part of my responsibility to manage within the resources that are allocated. And I think the challenge that's in the text there is absolutely spot on. It's one that we need to try and get the balance right between making sure that we're filling the posts that are delivering the most value for patients and service users across our region. And the only thing I can say in that regard is that at least the decision making now is within our region. So if we can agree and disagree amongst ourselves, but the ability to change it is within the region, and that's important.
And folks, I thank you for staying with us. We are about 10 minutes over, but I think we got through a lot there. So, Tony, if you don't mind, we might commit to doing another grilling in the new year with you at some stage.
So I definitely, and I really, first of all, I appreciate the fact that so many people come on, and I really appreciate the engagement and the amount of questions that people forward. In fairness to people, I really appreciate that. I do believe that actually it's this kind of questioning and teasing things out that maybe helps to give further clarity. So I think that is useful, and absolutely, without a doubt, I think we will be doing this again in the near future. Just in terms of the next steps and what I would ask people to do, I mean, what I'll be doing is we will be continuing to engage within the region with our own people to try and figure out the answers to some of the questions that have been asked, and to figure out that layer of management underneath the IHA manager and how that fits with the networks. That's what we'll be doing over the coming weeks. We will then communicate that and try and give ourselves as much time as possible to implement that across the region. And so we'll be engaging with our own staff then about that as early as we can in January. What I would ask people, I have a few key messages. One of them is the 3rd of March. Please bear that in mind. That's a deadline that we're working to, and deadlines have been helpful to us in this process, because it's stuff that you need to really get focused on to get an answer to. And so the deadline is useful to us from that perspective. So I'm asking everybody on the call to remain focused on that 3rd of March deadline for sure. The second thing is one that actually Anya McNamara raised, I think, the last time we did this, and it's just to remind anybody that hasn't thought about doing it so far, if you're just kind of intending to get the vaccinations and to get your winter vaccinations, go and do that. There's still an opportunity to do it, and there's definitely still a benefit to you and to patients and service users if you do it. And you'll find the information on the HSE website of where you can get that most easily in your own area. So that's just a kind of me hijacking this process. And last and final message is just conscious of the time of the year that we're heading into, to wish everybody a very happy Christmas, and hopefully a good Christmas as well, and looking forward to engaging with everybody again in the new year.